This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organized compartments and customizable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about innovation in pre-hospital care with John Martin. So we're really privileged to speak to John today. He began his career in a microbiology lab at just 18, but his passion for healthcare and emergency medicine led him to become the chief executive of SWASFT Ambulance Service NHS Foundation Trust. So with a distinguished career spanning the leadership across ambulance, acute and community healthcare settings, he's also served as the president of the College of Paramedics, advocating for the evolution of paramedic profession, but also as a visiting professor in Paramedic Science, shaping the future of paramedic education and training. So in this conversation, we're going to explore John's leadership transition from London Ambulance Service to SWASFT Ambulance Service, but also some of the biggest challenges facing pre-hospital care today. We're also going to look at the role of technology in modernising emergency care. We're also going to discuss mental health, interdisciplinary collaboration, but also John's vision for the future of paramedic practice. Welcome to the podcast, John.
Hi, great to be with you.
John, I just wondered if we could just start, maybe just bring you right back to the beginning, actually, and just if you could just share your journey, really, starting at 18, humble beginnings in a microbiology lab, and just that career path to becoming the chief executive of SWASFT Ambulance Service.
Yeah, so it's been a really interesting 25 years, really, in developing as a career. And you mentioned microbiology, so I'm going to go right back to that, and probably why I found myself in a microbiology lab. So I'd done my work experience with the Public Health Laboratory Service when I was in sixth form college, testing infectious diseases, and I didn't get the A-level grades that I wanted. Some people might say I failed. I won't go through my grades now, but I effectively found myself at 18, not with the A-level grades I wanted, not having a university place and wondering what to do. And there was a vacancy for medical laboratory assistant at the place where I'd done my work experience. So I went back there, and I spent a year testing infectious diseases as a medical laboratory assistant. At the time, it was back in it would have been 1998. Something called MRSA, methicillin-resistant Staphylococcus aureus, was all over the newspapers as this horrible thing, and that was one of the things I was testing. So it was a good introduction to healthcare and making a difference for patients, albeit being remote, but that idea that you could make a difference. And it was during that year that I wondered what I was going to do. I resat my A-levels in the evenings, was thinking about applying for university programs, wasn't quite sure at that point, but I did know I wanted to do something clinical. And the University of Hertfordshire, I lived in Luton at the time, and so I presume because we were fairly local geographically, a leaflet came through my door for the University of Hertfordshire program in Paramedic Science. It was new, it was just starting. In fact, 1998 was its first full-time year for a Bachelor of Science in Paramedic Science. I thought, oh, this looks interesting. Ambulance had been one of the things on my list, but you had to be 21 to join the ambulance service, and I was only 19. So I thought, well, I'll do another year at Public Health Laboratory Service, testing diseases, apply for that. But they actually had some clearing spaces, so I managed to clear onto the Paramedic Science program. So I went from putting an application in, I already had my A-level grades, so I was able to clear and then get a place. And within I don't know, something like 8 weeks of applying, coming with clearing work. So I was sitting in a classroom learning to be a paramedic with the University of Hertfordshire and London Ambulance Service. So yeah, so that's the start. That's the microbiology. I think you want to know how I ended up as chief executive of SWASFT Ambulance Service. So if I take you through a bit of a journey, finished, graduated as a paramedic in 2002, then joined what was Bedfordshire and Hertfordshire Ambulance Service. So it was in the days where there were much more, I think it was about 35 ambulance services across the United Kingdom at that point. So I, instead of staying with London, decided I would join my local ambulance service, which was Bedfordshire and Hertfordshire. Worked front line at Luton Ambulance Station, which is where I lived, and had a really good number of years out responding in ambulances, local population, place where I grew up and lived, and my various crewmates, so initially some established people, and then very quickly taking on, as often graduate paramedics end up having, even today, don't they? The new people coming out of training school, as was. And it was that really sparked my interest in education. So I started volunteering on my days off at the local training department. So that was up in Bedford. We were still running what were IHCD, Institute for Healthcare Development courses, back in there. And I just on my days off, I decided I'd go in. So I guess top tip to start with, part of the reason I think I am where I am is how you use your time. And not everything has to be paid for. So I volunteered and took on some things in my own time for my own development, but actually to help out the education centre. So I was doing a bit of volunteering on my days off, got involved in education, and it was that step really that I moved into clinical education as the next step of my career, having done a number of years in a frontline role. Eventually got a position of, the job title was Assistant Clinical Services Manager, which is an acronym, ACSM, as we like to have in the ambulance service. And that was a band 7 role, and was a combination of teaching and being out clinically and looking after people in a local geographical area. So I was doing their ride outs when it came to assessments as well. So it's a good role where I spent some time in the classroom and some time out clinically assessing and working with people, and sometimes on return to work, those sort of assessments that you did. So it had a good time in education. That's still one of my passions, really. One might get back to that later on in the podcast. We then went through various mergers as ambulance services, sort of in that transition. So I was in education at the time we started merging. Eventually ended up in a post of clinical specialist, which was a bit of an odd post in the sense that it reported, it was only an 8A, so a development post. I'm giving agenda for change bands here, so people are listening internationally, where you might have to look these up to see how you get paid. But I moved up a pay band into a role, and I reported directly to a medical director. So although fairly junior in the organisation, my line manager was the medical director who sat on the board, who wanted to develop a post of clinical specialist to look into clinical pathways and how they operate across what was the East of England. So that was my real step into leadership. Didn't have a team. I was working directly for medical director, did a lot on data and analysis and developing pathways. And it was in the days where pretty much we took everybody to the local hospital, and most of those patients were going to hospitals. So some were non-conveyed, but not many. So I started working on what would we do for patients who had falls. Could we have a different pathway for them? Started looking at stroke pathways and whether or not taking them to the local hospital was the right thing to do, or should you go to a hyperacute stroke unit? And there's also the days of trauma networks emerging, primary percutaneous coronary intervention, so PPCI for patients who are having a myocardial infarction, etc. So it was all of that I started working on. Various leadership changes. I eventually became a consultant paramedic in East of England. So it's the first appointment of that in the East of England. Consultant paramedic following the national description of that. So it was a combination of looking after education, one of my passions, research and audit, and leadership and clinical leadership. And it was an associate director post. So I reported to the medical director again in that post. But we've been through a number of medical directors, a number of changes. So I've sort of skipped a few bits out, but it is education route into clinical, into ultimately consultant paramedic. I also did, I guess, another top tip on top of my volunteering. I had a few little secondments, usually not for very long, a few months at a time, worked on some projects. One of them was with Skills for Health, writing the curriculum guidance for paramedic education. Did a different one with the Department of Health, looking at some analysis. Did one with what would now be NHS England, but was strategic health authorities in the day. So again, just looking for opportunities to develop my own knowledge, but also contribute. Then ended up with an acting director position at East of England. So East of England Ambulance Service went through a bit of a tough time. A number of the directors left. I was the consultant paramedic, and I was asked if I would act up for 3 months to cover the director of quality and patient safety, I think was the title. So it was my first introduction to really sitting on the board. I've done quite a lot, like just below board level, so trust board level. Said I'd do it for 3 months. 15 months later, I was still in post. We'd been through, I think, 3 chief execs in that period or something like that. And it was at that point that I saw advertised a leadership program. And I'd got to a point in my career, I'm still very passionate about clinical, but I increasingly was running things. I was responsible for lots of people. I was responsible for lots of governance and what was happening. And I was thinking, well, I've managed to do this without really much of a focus on leadership. And it was this program that was advertised. It was it was run by the NHS Leadership Academy in collaboration with Harvard University in America. And I thought I would take a punt on applying to get into that, and it was full time. So I did manage to get a place. It meant that I left the ambulance service at that point, and the rationale for that was we had to go and work with an experienced chief exec that would mentor us, and they found them for us. So there wasn't one in the ambulance service. So I joined Cambridge University Hospitals. Adam Brooks is the other way it's sometimes called, in Cambridge with Keith McNeil. He was the chief executive there as my mentor, and I, alongside doing the leadership program, which did mean I got to go to Harvard in America, just if you're wondering if all that partnership was about, for a month, and then I went back later for a couple of weeks, a year later, was a great opportunity to understand leadership theory. But when I was not over there studying, I was here working alongside an executive team in Cambridge University Hospitals, which was a great opportunity to be part of a board as we did that. I stayed on there for a year as director of integrated care, which is all about flow through the hospital. I think important, actually, we might talk about this later, for paramedics to be thinking about, well, we don't just work in isolation, either as a profession, and certainly not as an ambulance service. Then I moved to my role as director of integrated care was a flow through the hospital. It meant I did a lot of interaction with our community provider. They then had a job advertised running their older people's and community services as a director. So I applied for that. And so I moved from the hospital to community and mental health, did 4 and a bit years in community and mental health, heading up the one of the directorates there, which was all about treating patients who are over 65, so whether they have mental or physical conditions, as well as community services. Was also an acting chief operating officer there when there was a vacancy, and I, going back to doing secondments or opportunities when they came along, set up what was called the New Care Models Collaborative, which is about 6 organisations coming together. And COVID hit during that period as well. So just towards the end of my time at Cambridgeshire Peterborough Foundation Trust, which is the name of the organisation, set up the COVID response. I think this is where paramedics do come into their own. There was a bit of a let's look at the paramedic on the leadership team when we're going into a crisis, and that ability to do that. And it was in that year, 2020, that London Ambulance Service, towards the end of that year, so our first year of COVID, advertised for a chief paramedic officer, which was the first time I'd seen that in the country. Well, this looks interesting. I left the ambulance service to go on my leadership program, and I was out for like 6-7 years of my career. But I was always looking for the right opportunity to get back in. I thought this one, so it was a board level position. It was to take on professional leadership of paramedics within the London Ambulance Service. And applied for that, was successful. So beginning of 2021, joined London Ambulance Service. Again, COVID was a bit funny. We could probably do a whole podcast on COVID and how we responded to it. But joined an ambulance service. I'd lived for a year of it, and I'd carried on. So I carried on having a bank contract as a paramedic. So I'd done some clinical shifts during that year from East of England to my local service. But joining at a time where I was like buzzing really to get back into an ambulance service, what we could do, and joining an organisation that was under quite a lot of stress. And 2021 was probably a more difficult year, or was a more difficult year in terms of responding to patients than that first initial year, where actually although we had lots of uncertainty, no vaccine, etc., actually demand was very different to what panned out in 21 and beyond. So did some time at London Ambulance Service, including as deputy chief executive, and role changed around during that. And then it was November 2023 that South Western Ambulance Service advertised for an interim chief executive. Spoke to my line manager, Daniel Elcleys at London, so said, I'm not sure I'm quite ready to do this. I've only been a chief paramedic for 3 years, but I had been deputy chief executive. But in the back of my head, I thought there wasn't a definite, I want to be a chief exec. But there's only 10 ambulance services in England, and the posts don't come up very often. Having said that, quite a few have come up since I've been in the Southwestern Ambulance Service, but they don't come up very often. Well, do I do this now? And it's a nice part of the world to come and live and move my family to. So I came on an interim basis, and I then got made substantive just about 12 months ago from now. I just taken quite a bit of time there, but hopefully that's given you a bit of an insight into how I've ended up. And interspersed with that, I guess, a love for education. I completed a doctorate in health at the University of Bath part-time. That took me 10 years. And I guess I think because of the knockbacks of me not getting the A-level grades I wanted or was predicted, probably did me some good, because it sort of renewed my, actually, I do love learning. I'm just not very good at studying or exams, but interspersed with other bits, I've done my independent prescribing, I've got a minor illness qualification, just that opportunity to take it when it comes.
Well, John, there's a couple of things that strikes me just from really your whistle-stop tour through your career. One is saying yes to most opportunities and having almost this growth mindset where it's about versatility and adaptability. But another is about just, I think, in a way, just being a lifelong learner. And actually, you're right. Not just because you didn't get the A levels doesn't mean that's your lot, or that's where it ends. In fact, that's where it starts. And like you say, reimagining it and reinventing yourself as you go, but also just really transitioning through. One of the things that really strikes me, and I've realized this more, was basically there's power in stepping away. Actually, if you're to gain various different types of leadership, there's certain elements, I think, sometimes of leadership and of industry that actually can only be found in different contexts, and actually mentors can be found throughout life. And actually, it's not to say never for coming back into an ambulance service, which is true to say for yourself. It's learning the trade of leadership, of governance, of stewarding good decisions, of feedback, of reflection in these different contexts, and so they can all compound forward into a leadership role. And I think I'd like to maybe ask you about that, because like you said, this was maybe became a substantive role as the chief executive of Southwestern Ambulance Service. Leadership isn't something we naturally learn as paramedics, but it is something we start to embody over time. And I think, you learn to lead on scene, start to lead a small team, flash teams, and actually a macrocosm of that is leading an ambulance service. Could I get you to speak to that transition, and how you found leadership within a chief executive role within SWASFT?
Yeah, sure. So as it sort of alluded to, my leadership journey, I think like many of us as paramedics, we sort of do it. We're good at rolling up our sleeves and getting stuck in. So whether that be the first time we're on scene with multiple people. I remember my first time in right at the beginning of my career, Luton Ambulance Service, so coming in one night, and it was the station manager was going home because they'd finished their day, should say, and I just I'm trying to remember if I was or wasn't a one pip. So first rank station supervisor. You're it tonight, John. I said, what do you mean you're it? So we've had to move the staffing around, so you're going to go on a car. And just you're the only paramedic on in South Bedfordshire, and so you sort of everyone else is a double tech ambulance. There you go, and here's the car keys, so there you are for night. And I remember we had a road traffic collision on the bypass, and rocked up to two other ambulances on scene, so 4 technicians there, and we had a little debrief afterwards at the end. So we were pleased, but you sort of step into leadership, and we sort of taught it a bit. I guess that the epiphany light bulb moment for me was when I had that time out, as you say. Having a gap is I think can be really good for us, especially if you're a reflector. So I've done all of that intense period, quite a difficult period in the East of England Ambulance history. We've rolled my sleeves up, got stuck in, was doing media as a director of the ambulance service in the face of some pretty horrific cases we'd had in the media. Landed in Harvard. And I remember being in my hotel room thinking, having been like the first few days of lectures, thinking, why had no one ever told me this before? And it was then when I looked back and thought, well, actually, clinically, I pride myself a lot on evidence-based medicine. I'd want to keep up to date with the latest guidelines. If I wasn't quite sure what I was doing, I'd do it. But for leadership, I hadn't done any of that. I hadn't really read any of the literature. I hadn't looked at the research studies, of which there are lots, and there's lots of opinion pieces out there as well. But I treat it a bit like I do medicine, really. It's a bit like giving a drug. There's some really good studies out there, and I'm quite intrigued about how they work and how people function within that. And I would say if you're starting out on your journey, just doing a little bit of reading of the literature into leadership and what makes leadership models will serve you well. I think another point you made, I do privileged to do a bit of interviewing now for other people who want to get into posts. And I would say as a profession, one of the bits I've noticed we struggle on is that breadth of understanding across what is healthcare and certainly what is governance. So when I interview for whether it be consultant paramedic levels, chief paramedic levels, etc., we've got some fantastic paramedic clinicians who are brilliant. But when you ask them about understanding how an organization actually functions, I would say paramedics generally struggle there. We don't get taught it well at undergraduate level. Might do it at masters depending on what you study. So I think that opportunity, not saying that means you have to leave the ambulance service, but I certainly would embrace that on my leadership journey. And then being able to see how things like teams function in a different context. So community mental health, their whole structure, their setup, what does governance look like? What happens when you've got a patient who's on your caseload who dies by suicide? How do you investigate that? You wouldn't generally see in an ambulance service, but being able to understand that governance is there. So opportunities, whether that's secondments, talking to people or doing some learning, I think it will serve people well if they're coming for senior leadership posts as paramedics.
So, John, part of your leadership journey was being the former president of the College of Paramedics, and really, as I guess, as a formative role that really is pushing the paramedic profession forward and evolving the paramedic profession. Could I get you to speak to what you perceive to be sort of the future developments of the profession? I mean, it really has, since myself and yourself were at university, the breadth of roles and diversity of roles has absolutely blown up. But could I get you to speak to really where you see the role evolving at the moment?
Yeah, and I think you make a really interesting point. When we started back at Hertfordshire all of those years ago, I joined the ambulance service and the paramedic profession thinking they were one and the same thing. And I think that's the first important distinction to make is I just assumed that you'd be a paramedic in the ambulance service, and the ambulance service is where you'd be until you retired. And we see now an explosion of opportunities for paramedics and the paramedic profession in a whole host of areas. I managed to do my minor illness qualification, spent some time working in primary care. Obviously, I've worked as a director in hospitals and community and mental health, but we're seeing, whether it's leadership roles or clinical roles, paramedics to be there. So I think that separation of ambulance and paramedic is an important bit that's made. And I think the College of Paramedics has really helped with that journey, because it's not the professional association of ambulance people. It is the College of Paramedics, and putting itself on that footing of saying, well, actually it's a profession, and wherever paramedics work in whatever context, that's important. And I hope we don't ever lose our roots in what is the ambulance service and that really emergency. But where it's evolving to, I think we're seeing quite a lot in the urgent space as well as the emergency space. So we've seen definite development, and many of us will have joined this for the critical care end, that the hyper acute patients, but lots in that space of patients who are ill, and they are and they are in need, but you would put them probably in the not hyper acute category, and our development within that space. I think the other bit that's really interested me as how we've developed as a profession. So there's the context in which we work and those other settings. When I first started, when 3 lead ECGs. It wasn't a 12 lead. We didn't have them on the ambulance. The most pain relief we had was Nubane. We didn't carry paracetamol. So we've evolved a lot on our skills. And I remember when I first became consultant paramedic, which would have been in 2012, so 10 years after graduating as a paramedic. New to these episodes, when I was out and about, lots of questions I got is what extra things have you got in your bag? I remember doing a presentation on this, but yeah, what are the extra tools? What are the extra medication you got? And I guess as I've yes, that's important. And we all prescribe. You can access what's in the bin. Can I stick this needle in you in a different way to someone else? But actually, what's most about developmental is about the way we think, the way we understand why we take the interventions we do. And certainly, my time in primary care, I was more interested in why we were not doing interventional medicine. That ability to really work with patients in a different way. I saw a lot of it when I was working in mental health as well, as the skill set that isn't just about some of those tools that we would generally aspire to as paramedics. I think we all like a bit of kit. Well, what's the new bit of kit that you've got? So I think the evolution of paramedics is probably less about keep developing the tools, which is going to be part of it, but what is our thinking, our ability to rationalize and to work with patients. And our curriculum has developed in that way, but over time will continue to develop. And I think that sets, in some ways, the UK apart from some other parts of the world that when you look at it, do have, you could say, a greater scope in terms of tools. But actually, when you look at the underpinning rationale about why would you use that, it's very protocol-led versus guideline supported decision making led, and I would advocate for us as a profession to keep getting into that autonomy. And I think that is why we're so well respected in other arenas now, because we go in as a profession that can rationalize its decision and give a good answer to why we chose to do or not do, as importantly, an intervention.
Yeah, listen, I would wholeheartedly agree with you actually, John. And like you said, that critical analysis and rationale and being able to, like you said, support your decisions with fact, but also data and maybe a plenary approach as well, just to bringing others along with you. And I think you're right, that serves you well across industry. It certainly has served me well in the corporate world as well as the ambulance service. Could I get you to speak to, so bringing it right back to where you are now, John, and some of the challenges you are broaching and indeed tackling within Southwest Ambulance Service, and just to give international listeners a feel really for some of the organic challenges that we do struggle with within the UK or indeed wrestle with. Could I get you to speak to some of the current challenges within pre-hospital care that you and the way you're addressing them at the moment?
Yeah, sure. So, so to give the whole, so Southwest Ambulance Service is in the, if you're looking at a map of the UK in the bottom left-hand corner, covers about 10,000 square miles. So it's 20% of UK land mass. So it's big geographically, it's biggest ambulance service in England geographically. We have about 6 million people living in that area, and they are pretty well spread out. It's quite rural. We've got one big conurbation, that's Bristol. So Bristol's about 1 million people, not dissimilar to London. It's just on a much smaller scale. So London, about 10 million in London. So Bristol, but the rest of it is highly coastal. And what comes with that is quite a lot of older people and the associated frailty. So we are a popular place for retirement in there. So compared to some parts of the UK, certainly compared to London, we have a much older population, which we'll come back to that in a minute, what that means for demand and how we care for our patients. We've got longer running times to hospital. So somewhere like Cornwall, so that's a county right on the end, has about 600,000 people living in it. That is only got one hospital in it. So that is the hospital that you're going to, despite being that. And it's not unusual driving sort of end to end, it's sort of 3 hours in different directions from there. Which I guess if you're in Australia or other places might sound like, or the middle of some parts of America might not sound like that big, but it is certainly for England is an interesting geography and a service to be taking part in. So the challenges. So we, like all ambulance services in England, have sort of been through a post-COVID period. So demand went up a lot in that period, and certainly acuity of patients and access to other services. We've been through that, and that means that our response times have increasingly been getting better, but we struggle as one of the taking the longest, so slowest response times in England. We have a significant issue with hospital handover delays here. Some of that I think is driven by our geography. So you're only having one hospital, you can't divert to the next one because the next one's like a good hour's drive in the next direction. Unlike when I was working in London, you could sort of drive between hospitals if one got busy. That I mentioned the frailty of the population. So when we've got that, then often admitted into beds, and then they need support to get out of the hospital at the other end. So I think those combination of factors have made a difference to our response times here. Yeah, pleased to say that they are improving, but they're not at national standards. They're not where we want them to be, and they do make us slow comparatively to other ambulance services in the country. So that definite focus on hospital handover delay. So by that we mean the bit in the front door. When I was in Australia recently, they referred to it as ramping, which I thought was quite a good word because they're generally sitting on ramps in Australia, but we don't use the word ramping here in England. So I think hospital handover delays, staff retention. I mean, we've mentioned other opportunities for paramedics. We had quite a lot of our clinicians who stayed during COVID, wanted to see it out, do their bit. I really resonate with that. As I said, I was working in community and mental health at the time, got to the weekend, and I started doing clinical shifts for the ambulance service locally, really on the basis of I felt like doing my bit. I felt like a bit like, well, why am I not doing doing my bit? And I think we saw a lot of people who then did that, and then some leavers who'd got really to the end of their career, often retirement, to do that. But I'm pleased to say again, actually, we are. Our retention rates are improving, and I mean it sort of relates to that. Having said that, ambulance service staff survey results across the country in England. So the NHS, National Health Service, does our staff survey of all of its staff. I think it's the biggest staff survey in the world. Ambulance services rate the worst of what's happening in the NHS. So there's definitely something about what is our culture, how do we support the development of that? And I would say that's a challenge as much as it is in Southwest as it is for the rest of English ambulance services and probably beyond the United Kingdom. What does it mean to be a paramedic and a clinician here and our morale? And so I would say focus on people, focus on patients. Touched on it earlier. Changing demographic is making a difference for us. And another analysis that we've done recently focused on is how long do we spend per patient. And this has been a definite change in recent years. So over the last 10 years, and exacerbated during the COVID period, where for every patient we go to, we spend longer overall, because that includes the hospital handover bit, but longer on scene than we used to when you and I started. I don't know, guess at how long we used to spend on scene with patients. Now, some of that is clinically the right thing to do, isn't it? So I mentioned jokingly 3 lead versus 12 lead ECGs. It takes a bit longer to do a 12 lead ECG because you have to put more dots on the patient, but is the right thing to do to get to a diagnostic. But I think there is a challenge for us as a profession to think about what are the interventions we are taking. Are they all necessary for every patient in that context? And what is our responsibility to the population as a whole? And those extended, compared to where they used to be, on scene times, have we taken a rational way of looking at that, or have we just allowed, because we take more of a social history? So we take more of a social history, we rather than going back to asking ourselves, why in this case is it the right thing to do? It probably became prevalent for me when I did my time in primary care, because if anybody's worked in primary care or general practice, you've got your list of patients you need to see, and if you don't get to go home at the end of your shift until that list of patients is seen. So you are making some decisions partly based on that, and working in a team model around that. I remember not very many shifts into primary care one of my GP mentors said to me, why do you always ask when they get up from the chair, John, to walk out, is there anything else you can help them with? Because the suggestion being that if that was the reason they were coming, they would have have asked you in the consultation. And I think as paramedics, we want to be helpful, don't we? I think that is a trait of us. And it's not unusual when you are in the ambulance service and on scene and you're sort of taken out of the plan and you're on there to do everything you can for the patient in front of you, which should be admirable. But I think if you want to talk about the future, moving back a little bit and say, well, actually, how do we care for the population as a whole? The answer might not be just keep making more and more ambulances that spend longer and longer with patients. We might just have to readjust what is our thinking and our justification for the interventions we're taking. For that, you might say the case list as a whole, if you're working in an emergency department or in a GP practice where you've got your 20 patients to see, how do you do the best for them as a whole?
Yeah, no, indeed, and to your earlier point, and partly this is really ties into the innovation that you saw early on and that you were fostering and advocating for, really, which was around the network effect. Major trauma networks, stroke networks, COPD networks, frailty networks, just starting to think differently, but having some robust data to both back this, but also really encourage the use of streaming patients in these different directions, which is this concept of generalist through to specialist. And I'm acutely aware some networks work better than or more established than other networks. But to your point around actually maybe with not withholding, but certainly understanding the patient journey through to that specialist and maybe understanding is the intervention needed now in a less acute situation versus is the intervention needed more towards the specialist in a controlled setting and understanding that interplay. John, can I get to speak to quality improvement at the moment that you are undertaking, and indeed just to both enhance patient care, but also just really raise the bar on quality improvement within SWASFT?
Yeah, see, a key area of focus is how can we do better for patients. And just to your last example, I think there's a bit of a mindset shift here. I'm aware I've generally talked about paramedics, obviously a profession I know, but recognizing lots working in pre-hospital. We're doing a pilot down here at the moment for stroke patients and being able to link into specialist stroke nurses and consultants. We were doing similar in London ambulance service. I think there's a mindset shift where I think we've been quite proud in the past, I would say earlier on in my career, to say, well, I'm a paramedic, I know it, I don't need to ask for help. Actually, that network approach, multidisciplinary of asking for help, gets better decisions for patients. It doesn't mean that we are bad paramedics because we're asking for an opinion. That in fact actually makes us better. And in other professions, that is a more common. I think we're seeing that trend. I mean, it's one way of we can think about improving our quality is how do we all lean into patients to get to the right decision for them. Now, quality improvement more broadly, this is an area when I was doing my earlier clinical posts in my career. I remember when the 2005 resuscitation guidelines came out. So when we changed to compressions at a rate of 30 to 2 versus 15, and we were doing 3 shocks rather than 1 shock. And it was one of those areas that really sparked my interest on going back to this why of clinical knowledge. I wanted to understand what it was, then developed the education program for all out. But I very much wanted to not just say, well, here's the new protocol, you must follow it, here's the new flow chart, but we developed some teaching sessions around. So I think there's an element that links back to my earlier career on education about how do we do improvements in quality. So not just another diktat from the centre, but you explaining why we're doing it. And then I guess the other bit that developed it for me, and now we're exploring here in the Southwest, is what is the science. I've talked about science behind leadership. I've talked about the science behind our clinical interventions, why we give the drugs we do. There is a whole science behind quality improvement. And I was fortunate to learn some of this when I was over in America with the Institute for Healthcare Improvement. So they've got a whole methodology they use on quality improvement. And you might have heard about statistical process control. Plan, do, study, act is one of the things that they're quite famous for putting into place. And I'm very keen that more and more people understand the science of quality improvement, grab those opportunities and do it. I think it comes with 2 parts. One is us learning that science and being able to put in practice. I generally think any practitioner can put this into practice. You pick the project and you can certainly come up with a plan and you can study it and understand the data and how it moves. And then there is a bit that for those of us who are in governance roles in an organization to work out how do you have a governance structure which is robust and is safe, but also allows people to do quality improvement as close to wherever the quality improvement is happening as can do. And I think historically, and this is true for probably the National Health Service, a lot of that happens in the centre, whether that be their headquarter phenomenon or divisional leadership teams, rather than saying, well, actually, there's a problem here in this area that needs quality improvement, and can they focus on it and own it? So two streams really. And we're just early on in our journey. We've had a number of initiatives that have worked really well down here in the Southwest, but I'm keen about how does it become an everybody issue if we're genuinely going to drive quality as a key thing. And it would be very strange for any practitioner, I think, to come on and say they wouldn't want us to be delivering better services. So the more we can get involved in that, rather than just replicating the same. I think the other reason that quality improvement is so interesting, and I thought about my career, is all around us, things are changing all the time. So what we were doing 20 years ago probably was the best we could have done it then. But if you're still doing it 20 years later, we've missed what's happened around us in the world, in knowledge, in science, and therefore keeping up with that is important.
Yeah, absolutely. I couldn't agree with you more, actually, John. So just actually double clicking on that, actually, and looking at interprofessional collaboration and how we interact differently with other disciplines. Really interesting, like you said, there's a real shift towards primary care and how we can both support GP services from advanced paramedic and indeed advanced paramedic perspectives and within an ambulance service, how we stream patients better, but also again around, as you were saying, mental health. And an initiative within London was we're just about to do a 3-part series with the mental health team in London Ambulance Service on various aspects of mental health and how mental health services interact in the pre-hospital phase of care, both from a response model, but also triaging and online support. Could I get you to speak to really how we foster better collaboration amongst these disciplines? I mean, you have organic experience from working within community mental health. Could I get you to speak to how we, I guess, in a way, move paramedics closer to these services so that we can, I guess, treat patients better?
Yeah, well, I guess an apology for me to start with, which is I as a naive paramedic thought I understood mental health 111 services, general practice, etc., until I went to work in some of these settings, and it's because we see of what they're doing, of the 100% of what. So we'll start with mental health because you touched on that. For what is the 100% of what they're seeing as the mental health provider, we are probably picking up in ambulance service context 2 to 3% of what they're doing. Until I started, so when some of the teams I had when I was working as a director of mental health included the dementia wards, the organic older people mental health wards, as well as some rehabilitation wards for physical health, as well as crisis teams. We had old people and the actual patients they're seeing that don't come anywhere near the ambulance service, who are really unwell, and the caseloads that they hold and the decisions that they're making on a day-to-day basis, I just did not understand. And I like I would maybe say quite a number of us have done, is just dismissed as typical mental health, not picking anything up again when we had a 999 call for a mental health crisis patients. I think the same is true for my time in primary care. Until I went to see the patient load that they were seeing and looking after, you just see, and we say the same about 111. That's a service we have here in England for international listeners, where it's the non-emergency line. But actually, most of the patients, by far the majority of patients, don't come to 999 who are looked after by 111. So I think the first is probably a bit of understanding and compassion between all of us, whether that's in undergraduate education, whether it's us taking opportunity, but maybe just a mindset that I've shifted to of not making assumptions, because we see one bit of it, we assume that's what the whole of that service is like. So I think there's something around that, and then a more so that ability to learn across by secondments. But you mentioned the London Ambulance Service mental health scheme. We've got similar down here in the southwest, where we're working with our mental health partnership organisations to have mental health practitioners out. So, what is the breadth of practitioners that are working in our call centres or out on our vehicles, and how we do that and how we foster that into collaboration. I think the last bit I'll probably just say around this is, for those in leadership positions, is how do you approach developing a collaboration? Is it that you're going in with your arms folded and you're starting with right, you're not helping us out here, you're sending us too many patients, what are you doing? Or are you coming to the table as equal partners where we've got a shared objective? It's a great project, the Harvard Negotiation Project. People can look up. It's written up in a book called Getting to Yes, which it takes a very different approach to what is collaboration, how you negotiate, how you separate out personalities from actually shared positions, etc. How you go with a positive mindset. And I think if even if you're just developing a local scheme with your local local practice, I think we would serve us well to start understanding how do we collaborate better rather than from a position of defence.
So I'd like to look at training and education, but before I do, I just would like to really look at how we basically utilize technological integration within modernizing pre-hospital care, and then some of the innovations that you see going forward. I'm just about to do a podcast with an AI company that are looking at how we integrate AI within dispatch models and indeed call taking models to make sure, because I think a large part of, to get to your point, John, what we don't see unless we actually go and see the services is that fatigue and, compliance. A lot of call takers are judged by compliance to an algorithm, but it's hugely fatiguing and stressful. And actually, vigilance and monitoring over 12, 13 hours can be extremely difficult, and picking up the subtle nuances which might constitute critical care versus urgent care. But how we embed AI and indeed technological advancement within dispatching and triaging, just to really, I guess, lean more on machine learning to help us carry the weight of fatigue and provide consistency of service, really service provision. But could I get you to speak to some of the technology enablers that you see and you're leveraging within Southwest Ambulance Service?
Yeah, so I'm sure, like most, probably across the world now, it's an area that's really ramped up in recent years, the artificial intelligence. But I think as a sector, we use technology, so we embrace it in two bits. So I'm probably interested to talk about the clinical bit. But when you and I started, we have got a London A to Z blue bound map book because there was no GPS, so we had to learn our way around London, and yet we embraced satellite navigation when it first came in. But I do remember quite a lot of frustrated, well, I wouldn't have gone that way. So there's something about how the technology evolves and how we embrace it. But now you wouldn't get a map book, and you just think that using satellite navigation is the way. And I think clinically, there's a bit of a mindset shift that needs to be similar. So we'll have all worked with ECG machines recently that attempt to tell us what it's read on the machine, sometimes useful, sometimes not. A bit like someone was talking about, that was the mindset should be, well, how is this going to be helpful to me while still remaining there, rather than just casting off that this might be might be a bad thing to do. And I think the technology, if we embrace it, will a bit like I've said with using our mindset around calling on other professions, other services. I mean, using the technology as something that can aid us rather than thinking it's something to demise us as a profession and take away our autonomy. Actually, it's about embracing it. And some of the, it sounds like you can do this on your other podcast, but some of the technology I've seen recently, certainly around ambient listening and how it can help with some of the subtle things we might miss, certainly in the call take environment. I mentioned extended on-scene times compared to where they used to be. Part of that is, and I've noted it because I do it myself, is how much we now write into the clinical record, and the use of technology could be very different around that. And we've just started using it for some of our meetings. So on a governance lens, can it summarize what's happened at a meeting instead of taking formal minutes? The same technology, I won't mention company names, I've seen be able to be used for clinical interactions to write up your clinical notes, and then our ability to pull the data in from any of our diagnostic tools, etc., and to populate a record, I think will really help with. Can we make this? Can we make this quicker? If we make it quicker, that means we can use that time for patient care in a different in a different way. And I certainly think diagnostically, the ability for computers to be able to see patterns that we would like to pride ourselves on being able to see. There is a difference, and there is an emerging science around that and its ability. And I think we are going to have to be mature as a profession about, well, how do we embrace that? And is that a slight on us and on our human ability? But I guess where I've got to is I've just got one brain and one set of cells that are doing that. If what you can give me is lots that bring it together to help the patient in a different way, why would we not be embracing that? But I think it's going to be a very different era, and I would suspect probably not right now, but an explosion in the not too distant future where we'll have to really lean in and embrace this if we want to be the best we can be for our patients.
So we're just running out of time. I've got three more questions. One really would be the training and education. It really is your roots, actually, John, around being a professor in paramedic science and really pushing the profession forward within paramedic training. And I guess that's one of the questions I'd just really like to tease out of you is where you see training going in the next few years.
Yeah. So I think I've explored already that the idea that really the profession is developing and setting ourselves up as paramedics to work in a variety of different environments. I think it's good for patients. It's good for us as individuals. And when I say us as individuals, when you go back to you join the ambulance service and you're going to do it until you retire, we know retirement age is getting up. Some environments are, whilst they can be stressful, might well be better for our bodies physically to be working in the latter years of our careers. So I think setting that up at the beginning of undergraduate education. I think alluded to the development of programs, whether they be masters or doctoral level, for paramedics to be experts in that and then to own our profession alongside other individuals and being able to do that. I think where technology goes, going back to our last question and what that means for education, I've got 3 teenagers, and they the way they just engage with media, how they learn is very different to me. And I think there's something about how our education is going to adapt for that, for paramedics, other clinical professions, and how we do that. And I guess they're probably where I would be, where I'd be looking. But I think really the world. I mean, this has always been true while we've been alive, but the world is moving at an ever increasing pace, and probably therefore what we need to learn is skills about how we adapt in that, rather than necessarily the skills themselves. If I was going to give you a professorial type answer, but instead of teaching people the very specifics of how do you teach people to learn and to keep up to date, and I think that is a shift for us where we've sort of been very much a core tool and now got to go on a program rather than that adaptive to what's going on around us and how we learn as professionals. And we've been encouraged to do it via the continuing professional development type standards that we've set was set by our regulator, and that essence of being a professional is there. But I think we could teach that more in the way we originally educate people to really have the skills to discover some of this and adapt to what's going on around them.
So, John, just as we come into land, just a couple of things. I'll roll this into one question actually, as to where you see SWASFT going in the next 5 years, and then maybe just a few words around aspiring paramedics that were coming into the trade. If you just had a few words for them, but one thing, and I'll just bring back some of your answers within basically what you said, which is fantastic, really, which is really bringing ownership back down to the grassroots level around quality improvement, so that there is, because one of the challenges of prescribed care, and you've said this yourself, is the remote nature of the staff base. It's a disparate staff base which is never really in one place. It's ever changing on a daily, hourly basis, and getting that semblance of community and ownership and pushing it down to grassroots level, but also quality improvement, training, education, and actually raising the bar for paramedic practice throughout the staff base, and preparing them for the future, as you said, in a multitude of ways, so that actually people are technologically enabled and prepared for shifts and changes. But could I get you to speak to where you're driving the profession forward within SWASFT, and indeed just a couple of words around aspiring paramedics coming into the profession?
Yeah, so in terms of Southwestern Ambulance Service, we before I arrived, we launched a 5-year strategy here. So we're just about to go into the third year. So 2 years, 2 years have gone in, focused not unsurprisingly on patients, people, partners, and the organisation as the 4 areas, and being the best we can be for the patients that we deliver. I think all of what I've learned in leadership is we've got to have a very definite, something that we focus on. And for me, that is patients, and how do we grapple with delivering the best patient care against the backdrop of the population we serve, a growing population, a population that's getting older, that is more frail. So a definite stream, you mentioned the next 5 years, on what is our best response to that for urgent and emergency care. We're definitely in the game down here. It's not just the emergency, but it is patients who are in that acute phase of urgent and emergency care, and how we look after that. But I've also become acutely aware, as I developed in my leadership journey, how important the people are. And I probably early on in my career, maybe I didn't really appreciate that. I was very much focused on the clinical element, and well, why would we not all want to give pain relief to patients who are in pain, to use one of the areas which I think we need to continually improve on. But actually getting into the people element, well, what's the environment? How are we cared for in that? So if there's 2 streams of work alongside our strategy of those areas, it is going to be, how do we continuously make this a great place to work? How do we adapt to that environment? And I mentioned my children, who will eventually all be in the workforce in the not too distant future, because the oldest is 18 now. What are they looking for from an employer? What are they looking for from a profession? And how do we create that environment? It might be different to where we've been historically. And then how do we do that? How do we then do the best we can for our patients across that, and how do we adapt to that around that? The other 2 parts of our strategy, that doesn't require having an organisation that adapts to it and has the right infrastructure. It does require working with partners. Ambulance services, I think, have been accused, and certainly in my time, ambulance services, of being a bit of an island, a bit of a silo. I mentioned it earlier, but that idea of how do you get alongside your partners, because ultimately we're all looking after the same population, and how we do that. So I think that's where I'd certainly see SWASFT going in the next 5 years, hoping we continually improve to where we are. And I'd want to make us a great, outstanding place to be for patient care, but also to work as a professional. And then in terms of aspiring paramedics, I hopefully alluded to it over the last hour, really. Your career really is up to you. Most of mine was not planned. It was opportunistic, with spotting things that came along. There's he's a Hertfordshire professor, actually, wrote a book called The Luck Factor. And basically his science is that people aren't really lucky. The people who are lucky are the ones who spot opportunity. So we all get to see the same things. We interpret it a bit differently. So I think to just look for those opportunities, take them when they're given. Keep your mindset open. So we talked a bit about growth mindset. So what are the opportunities to explore thinking differently, to develop yourself? And I think I've learned this over time, not to make assumptions either about other professions, other people that you're working with, and really get to understand, well, what's behind, what's driving anybody to be the way they are, and how that works. You probably psychology, looking a bit into psychology, and that would serve you well. If you're thinking about joining this profession, I've loved it, and I'm hoping I will continue to love it until I finish at some point. And at some point I'll finish. But I like the idea that maybe I'll still be able to contribute in some way for many years to come, either in a leadership role or in a teaching role. To that, and I think we talked a lot about paramedics, but I think the paramedic profession has it's growing in numbers, but it's growing in status and our ability to care for patients in a whole number of settings. I expect that to continue, and therefore I think that opportunity to join will give you a good footing to wherever you might end up in the world caring for patients.
John, that's fantastic and a great place to leave it, actually. Listen, thank you for last hour. It's been a real privilege just to speak to you. So thank you so much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.